Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is Why CPT Coding Ambiguity Harms Doctors. Muhammad, welcome back to the show.
Thank you very much for having me. I appreciate the opportunity to talk about this timely topic that affects the practice patterns of most physicians around the United States who bill insurance.
All right, so what's this latest article about?
So, in my article, I talk about the CPT coding. This is the current procedural terminology, which is the billing language that was established by the American Medical Association. And they established that in 1966. And by the 1990s, the federal government, the Center for Medicare Services, actually established that procedural terminology as the established pattern that they would take for Medicare, the Center for Medicare Services. And then ultimately, the private insurers actually also established that. So most of the time, physicians who bill Medicare or bill private insurers, they are using the CPT coding guidelines, and they are judged by the CPT coding guidelines. And what happened over the last 20 or 30 years, there's been a development, there's been a refinement of these codes and procedures. And we've actually saw that prior to the COVID pandemic, some of these codes actually changed. And basically, they were streamlined, things were made easier. And this kind of where this legal case, the United States v. Dr. Ron Elfenbein, comes in. And this federal criminal case was actually filed in 2022 and really goes to the heart of basically the current procedural terminology and how physicians use that and how the ambiguity actually can be used by the federal government to indicate that some of the action taken by physicians is a criminal action.
So I want to underscore how important CPT coding is because it determines how much revenue, potential revenue, a medical institution receives, how physicians are paid. Our entire healthcare system, the financial structure is essentially based on these CPT codes. Talk about why they're so ambiguous.
So the CPT coding basically has significant several components that looks at the documentation that physicians do in their notes, and it's called the evaluation and management codes, the E&M codes. And most of them are 5 number digits, and they end up, the last digit is usually between 1 and a 5. And a 1 signifies the lowest possible level code, and 5 signifies the highest level code. And most of the time, people, when they bill, they actually will start with a level 1 or 2, and then they may escalate to a level 4 or 5. In this case, in the case of Dr. Ron Elfenbein, who actually operated in urgent care services during COVID, he evaluated patients during COVID time. And he did COVID testing and he assessed them. And what ended up happening is there was not a lot of knowledge about what is COVID at that time and what are the consequences of COVID. And so he billed level 3 and 4 codes, and the government said, no, you should have billed level 1 or 2. And so that's how this legal case started. And he actually ended up going to trial and was actually convicted.
So tell us more about this case. So eventually, what happened to Dr. Elfenbein? And this is just to recap, he was billing level 3-ish codes for COVID testing when the government said that he should have been billing level 1 and 2 codes. Is that correct?
Yes. So the government initially said he shouldn't have even billed. They said, well, he just did testing and there was very little evaluation on these patients. But these patients had potential to have COVID and they could have died. There was very little knowledge about the disease process. So the government said level 3, 4, and 5 were fraudulent and they should have been level 1 or 2. It was very, very difficult for the jury to understand that. And basically, they ended up convicting him. The issue is that the judge looked at the evidence, the judge in the case, and said, this is very ambiguous. There was no way that the jury was able to reach this verdict with beyond reasonable doubt. And so, in a very rare move, he actually decided to override the jury's verdict and actually decided that he actually would be found not guilty. I feel that this case really signifies how these things are ambiguous. And when you put it to a layman's jury, it is really, really very, very difficult. What happened is the federal government actually appealed the case and it went up to the Fourth Circuit of Appeals. The American Medical Association actually put in an amicus brief, so basically a friend of the court brief, telling the court that they think that that is true, that these codes are ambiguous. However, the United States Court of Appeal for the Fourth Circuit decided actually to return the case to trial and ordered a new trial. So he is currently now battling another trial. The United States Supreme Court refused actually to take the case. So we have now a case where the CPT terminology and the CPT coding that's very ambiguous is being used against physicians in a criminal way, while all of these things, whether a note is level 1, 2, 3, or 4, sometimes has some concrete rules, but a lot of times it's actually very fluid and ambiguous.
In the case of Dr. Elfenbein, did he have documentation to back up his coding at level 3?
He did have documentation to back up the coding at level 3. And these were all patients that had the potential to have COVID, a deadly condition, unknown condition. So that's one of the criteria, is that if it's a vague, unknown disease, you are able to bill at the highest level because you don't know what's going to happen. Your patient could go to the emergency room, your patient could die. So you're allowed to carry the highest level of coding. And he had actually coding experts that suggested that. But, the jury, the layman's jury, this is something that's very, very ambiguous and very difficult to understand. If we physicians don't understand it, I don't think that they understand it also.
How common is criminalization of coding errors, such as the case we're describing today? Is this an outlier? Does this happen relatively frequently? How common is this?
We see it frequently, and we are seeing it more and more. And basically, the criminalization sometimes is associated with other things. So, for example, if there's suspicion that a physician is prescribing controlled substances and they want to get him for the controlled substances, they tag on coding violation. And we as physicians, when we practice and we code a note, the same note, a coder may have disagreement on the level, 2 level up and 2 level above. So it's very, very hard. It's very ambiguous. And we're seeing that the Department of Justice is criminalizing that action.
So, what can physicians do to protect themselves? You mentioned in the case of Dr. Alphamine, there was appropriate documentation. So, other than appropriately documenting, is there anything else physicians can do to protect themselves from finding themselves in that situation?
I think they need to be very aggressive in terms of self-auditing themselves. So looking at their own notes. Now, in the article, I also talk about now that we're seeing the private insurers actually are auto downcoding the levels of care. So if somebody sees a complex patient, it's a level 4 or 5, the private insurances are saying, without looking at the note, this is not level 4, this is not a level 5. We'll pay you a level 3. So we are seeing that is a significant issue that's happening, cutting into revenue. It's affecting hospitals, it's affecting private practices, and it's going to be happening more and more. We've also, as physicians, because we've implemented this ambient listening and transcribing, we've been able to capture more of the care that we provide to our patients. So that actually has improved our documentation. The insurance company is not happy with that, so they are auto downcoding all of our notes now on a regular basis.
I've heard about that too. So, when that happens, what kind of recourse do physicians have when their notes and visits are auto downcoded?
You have to fight like hell. A lot of places are not, a lot of physicians, practices, hospitals are taking it at face value, but unless we fight it, because it's a violation of the law, it's a violation of the coding guidelines, and they don't have the note. How do they know that your note is a level 4, not a level 4, a level 3, if they don't have the note? They just look at the disease process or auto downcode without even looking at the disease process. They just say, we're only paying a level 3.
So, what kind of ways can physicians fight this? From the insurer standpoint, I'm sure that the appeals process is going to have a lot of red tape. And the fact that it's happening to so many visits, physicians aren't going to have the capacity or resources to effectively fight back without cutting into their patient care time.
I think what's going to happen is that physicians are going to band together and there's going to be a major lawsuit against maybe one or two insurers. And the outcome of that probably lawsuit is going to drive what's going to happen and whether that practice is going to stop. Now, we are also seeing that the Center for Medicare Services is going to start implementing AI and is going to be actually doing the same thing to notes of Medicare providers. But that highlights that these things are disagreements in opinion. They're not criminal acts. And so sometimes the government prosecutes those as criminal acts, but they're actually disagreement in opinions about coding for a certain note. And they should be dealt that way in a civil fashion.
So, how do we get to this point? My understanding was that when the CPT codes were first unveiled in the 1960s, it wasn't really meant for billing. Correct me if I'm wrong. So, how do we get into this mess just from this billing standpoint, and how do we fix it? How do we make it less ambiguous?
It's our professional organization, the American Medical Association, actually contracted with the Center for Medicare Services. So the AMA actually receives revenue from the Center for Medicare Services and private insurers. For every code that gets billed, they get a percentage. It's very low, probably a part of a cent, but with the number of codes being billed, they get a big chunk of money. And so they have no incentive to basically change that. And I think it's a step in the right direction that they actually sent an amicus brief saying that these codes could be ambiguous and they should not be used to criminally prosecute physicians.
What do you see as a path going forward as it relates to the ambiguities of these codes being used to criminally prosecute physicians? What do you see as potential scenarios going forward?
I think physicians winning some cases where that gets established, and I'm rooting for Dr. Elfenbein to be exonerated in his case. Also, if the insurers and Medicare continue with auto downcoding, that organized medicine is going to get together and it's going to fight this. And unless there's court action, I don't see this stopping.
We're talking to Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is Why CPT Coding Ambiguity Harms Doctors. Muhammad, as always, will end with take home messages that you want to leave with the Kevin MD audience.
Sure, sure. I think physicians should be held to the American Medical Association current procedural terminology, but not to punish physicians for following it in good faith while treating patients. And I'm hoping that we're going to work on fighting CPT ambiguity and getting physicians the compensation that they're owed in taking care of their patients.
Muhammad, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
My pleasure. Thank you.